Coming up, it's painful, chronic, and hard to diagnose. Women of reproductive age around the globe suffer with endometriosis. Today, we pull back the curtain and offer hope for a condition that currently has no cure. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. Abby Parker is 1 in 190 million. That is the number of women worldwide who suffer from endometriosis. She joins us here in studio along with her OBGYN and endometriosis specialist, Dr. Austin Finley. Dr. Finley is also the Division Director of Minimally Invasive Gynecologic Surgery. Great to have you both.
Thank you.
Thank you.
Thanks for being here, Abby, to share. And we're going to start with your story today. It begins like a lot of women who experience endometriosis. Abby suffered severe life-impacting pain and sickness once a month until she finally went in search for answers and found the right doctor. Here's Jill Chadwick.
This is called Gin Rummy.
I would have to get up multiple times in the middle of the night to just try taking a shower or something to help with my cramps. I couldn't sleep at night, having to call into work and say sorry, I'm not gonna make it.
29-year-old Abby Price suffered years of painful periods dating back to her teens. Fast forward, and in 2015, Abby developed and had a huge cyst removed from her uterus, and later, trouble conceiving a child.
Jen.
Dang it.
A friend mentioned that her consistent pain and issues might be from endometriosis, a disorder where tissue that lines the uterus grows outside the uterus. Abby saw her doctor.
She dismissed the idea that I might have it, which is pretty common, as I hear.
That same friend suggested she see Dr. Austin Finley at the University of Kansas Health System.
I was already kind of wondering if there was maybe a connection, and then when I talked to my friend, that was when it was kind of like a light bulb, oh, maybe this is related.
Dr. Finley performed a laparoscopic procedure where he immediately identified endometriosis and removed it surgically. 1 month later,
Took the test just to get it off my mind, thinking it would be negative, and it was not. It was positive.
Abby went from years of pain and struggles
This is the day that we found out we were pregnant.
to canceling her infertility appointments.
We were supposed to meet with our infertility specialist for the first time, and I got to cross that off the list because we did not need to see her anymore.
You're not supposed to cancel important doctor's appointments, but we're so glad that you got to.
Yeah, that
So
was a great one to cancel.
Right? 13 weeks, so we
Yes.
can celebrate finally.
Yes, definitely.
What was it like to finally kind of get past that, get to that milestone?
Of 13 weeks, yeah, so last week was our 12-week appointment of the sonogram, and it was very exciting. I think I definitely had some anxiety the first trimester, which I guess I'm still in, but just is everything okay? Just kind of a imposter syndrome of am I really pregnant, and I haven't had horrible pregnancy symptoms. I'm very lucky and thankful for that. So that kind of added to my anxiety, and now that we're here and we saw a healthy baby and heard a heartbeat, I'm definitely feeling just super thankful more than ever.
Dr. Finley, that's going to make you happy?
Yeah, it's great. I'm so happy Abby could be here to share her story today, and it's just always awesome when we can have happy endings like this.
Absolutely. So no periods to suffer through while pregnant, but Dr. Finley, does Abby's history of endometriosis, does it pose any added risks while she's pregnant?
For the pregnancy itself, in general, there's not a high risk of complications associated with endometriosis. Most of it is more so the ability to get pregnant and maybe early miscarriage during pregnancy, but as the pregnancy progresses, those risks kind of go away.
Okay, let's talk about this. I've heard women having endometriosis. I'd hear it in conversations over the years, and just it seemed common, so common that sometimes you wouldn't even really dive deep into what it is. So tell us exactly what it is.
So endometriosis is considered a chronic inflammatory condition when there's tissue that's normally on the inside of the uterus, the endometrium, that develops and implants outside of the uterine cavity. And it's very hard to diagnose because more often than not, it does not show up on any sort of imaging study like an ultrasound or an MRI. So it's a very challenging disease to diagnose. and often requires surgery to establish a definitive diagnosis.
Now, Abby had these, this pain and just kind of literally suffered through it and just got used to it. So how would somebody know that they need to seek out your help and that they're not just somebody who has painful periods?
Yeah, so one of the unfortunate things with patients who have endometriosis is many of them go on average 7 to 10 years from the onset of symptoms before they receive an accurate diagnosis. And so that's a problem. So as physicians, we have to listen to our patients and have a high index of suspicion based on their symptoms to investigate or evaluate those symptoms further.
So the health system has endometriosis specialists like you, but how does that help in really making a proper diagnosis when you have that kind of specialty? And then, of course, how does that impact getting the right treatment?
Right, so every patient's different, and not every patient, even with endometriosis, necessarily always needs surgery. Endometriosis we manage sometimes by managing symptoms using medications, and other times it does require surgery to help improve those symptoms. And so just kind of taking each individual person's symptoms and goals in life, reproductive-wise or otherwise, kind of determines how we treat and whether somebody needs surgery. And then kind of go from there.
So let's talk symptoms. I mean, when you and I met, you went back to high school and you said it just kind of started from there. Take us through kind of your story of symptoms that led you here.
Yeah, so I would say my symptoms kind of ebbed and flowed at times. They definitely got the worst probably post-COVID or whatever that is, I guess, 2020 forward. And yeah, it just, it got to the point where almost every period, I was having to call in to work at least a day and say, like, I'm really not feeling well. And I was really in that much pain that I just, it was like I needed to be laying down. I needed to be like not responsible for anything. And then definitely, where it was keeping me up at night, I couldn't, I would be woken up at night just with really bad pain and have to like go take a shower or something and see if that would help in the middle of the night, or just lay on the bathroom floor. Yeah, just something to like maybe soothe with the cramps. But yeah, just really intense cramps, really heavy bleeding.
But you had that back in high school. So Dr. Finley, is that related? I mean, if you have a heavy period in high school, what does that mean for down the road?
Yeah, the pain, again, many patients, with endometriosis begin to experience these symptoms in their adolescent, teenage years. And again, many of those patients are dismissed as just, kind of being wimps or something like that, where they're told to just deal with their pain and their complaints, especially when they have significant symptoms like Abby, where they're missing school and work, are just often not taken seriously.
And you have nothing to compare it to. I mean, you just think this is just what life is.
That's your normal, right?
Right. I want to talk about a recent study labeled Landmark Research. It was published in the Journal of American Medical Association, showing that women with severe endometriosis are 10 times more likely to get ovarian cancer compared to women without endometriosis. Prior studies have showed only a casual connection. Tell us about the study and just your thoughts on it.
Yeah, so what that study showed is that women who have more significant endometriosis, like endometriosis cysts of the ovaries, what we refer to as endometriomas, are more likely to develop a specific type of ovarian cancer. It's not the most common type of ovarian cancer. And what that study showed, that there is a higher risk associated with women with severe disease. But what I like to talk to people about is, even though it showed a 10-fold increased risk in ovarian cancer, that sounds very scary. What that equates to is about 10 more patients per every 10,000 women with endometriosis. So overall, that risk is not severely high, and
well, thanks for breaking the study down. That's why you're important.
We try to
put it in context.
Keep people calm, in that regard, that
For
they don't
sure.
worry too much about that.
But what determines severe endometriosis?
So severe endometriosis is generally considered endometriosis that is more invasive into the tissue. So endometriosis can implant superficially, or it can be like deeply invasive into the tissue and even invade into the bladder, the bowels, ureters, things like that. So severe endometriosis is deeply invasive disease that often distorts the normal anatomy.
And is that because it goes undetected or undiagnosed?
A lot of times, yes. and there's probably some factors, related to the individual person, maybe genetic factors that play a role in who develops more severe disease and who doesn't, but there's a lot about that we don't really fully understand.
And regarding that study, what would the results of that study mean for someone like Abby?
For somebody like Abby, she had endometriosis, but not big ovarian cysts. So likely she is at a kind of normal baseline risk, in terms of developing ovarian cancer without a significantly increased risk based on her level of disease. But patients who have large endometriomas like endometriosis cysts of the ovaries may need to be monitored with repeat imaging and kind of followed for symptoms over time.
So I want to talk about how you treated this. Abby, you were told to go specifically see Dr. Finley. Tell me about that conversation with your friend.
Yeah, so I ran into a friend I hadn't talked to in a while, and she was catching me up on what she'd been up to. And she had recently been diagnosed by Dr. Finley, I believe, with endometriosis, and was scheduled for surgery herself. And so she was just kind of telling me how she came to that part in her journey. And she and her partner had been struggling with infertility for like over 10 years. And so it was a real big breakthrough for her to be like, oh, there is a reason for it, not just that I'm too stressed, which is what she'd been told before. And so as she was describing her symptoms, I was kind of like, oh, that sounds a lot like my symptoms. And she's the one that encouraged me, like, okay, well, I know this amazing specialist, Dr. Finley. He's who I'm seeing. I really recommend you reach out to him. So that's how I got connected.
Oh, good. Lucky to run into that friend.
Yes.
Here at the health system, we excise or remove the disease. How do you determine where to cut and how much to remove? What is the procedure? Kind of take us inside what that procedure looks like.
For most surgery for endometriosis, what I explain to patients is that my goals are to essentially treat it like a cancer, to excise or remove all visible disease. And so it does take a trained eye sometimes to recognize more subtle changes as far as endometriosis goes, but what we try to do is factor in the patient's reproductive wishes into what we do surgically. But in general, the goals are to cut out or excise with reasonably wide margins any lesions that we identify that appear consistent with endometriosis.
So when you talked about it spreading, so I'm thinking, now you got me thinking kind of like cancer. Is it like in one spot, or that's what you're doing? You're going in and looking, so and you can identify? Correct.
So we're going in and looking to identify where the lesions or the endometriosis disease exists, and then remove it from those areas. So most commonly it exists within the pelvis, but it can extend frequently to the intestines, the bladder, the diaphragm, really anywhere in the abdominal pelvic cavity. And it's been found in every organ system in the body, including brain, things like that. So that's less common, but things like that can happen.
So interested, you said when you met Abby, you have to ask this question: what are your reproductive plans? Tell me what that conversation's like with your patients, and how do you tackle it differently if somebody like Abby said, hey, I'm done having kids, or I don't want kids?
Sure. So sometimes with endometriosis, in addition to removing the disease, especially for women who suffer from significant pain with their menstrual cycle, sometimes hysterectomy or removal of the uterus itself can be beneficial, in treating or improving those symptoms. So obviously if somebody is desiring to become pregnant, that's not a consideration. But for women who have completed their family goals, that is definitely a consideration that is discussed in terms of improving symptoms with surgery.
So now, once you remove it, is it gone for good?
Well, in general, my belief is that the best thing that we can do when we treat endometriosis surgically is to physically cut it out, not just superficially burn it. That decreases the likelihood of any persistent disease and need for repeat operation.
What happens if it doesn't get diagnosed and it just goes on and on?
Yeah, so it can cause significant scarring and disfigurement of the pelvic anatomy. We do cases where we diagnose endometriosis and patients have essentially their organs within the pelvic cavity are fused together: the uterus, the ovaries, the fallopian tubes, the intestines, the bladder, all of those things. We call it a frozen pelvis, actually, is the term that's used to describe it, where everything just becomes fused together. And once the damage gets that bad, it's very hard to reverse the damage that's done to those organs, especially things like the fallopian tubes and as that pertains to pregnancy.
Here at the health system, we have endometrial cancer specialists. What's the connection? Could you just kind of give us a basic connection between endometriosis and endometriosal cancer?
So really not a correlation between endometrial cancer and endometriosis, more so ovarian cancer and endometriosis, but the tissue that is endometriosis is very similar to the endometrial lining, so where those cancers arise from.
Got it. Okay, thank you for answering that. I have more questions. If you have questions, you can use the chat on YouTube or you can email the Medical News Network. All that information is right there on your screen, so send in your questions. Dr. Finley, how exactly does endometriosis affect fertility? Does it affect egg production? Also, another question is it linked to more painful sex?
Yeah, great question. So definitely it affects fertility. Some of those things we just mentioned, like when it causes significant scarring of the fallopian tubes then do not function normally, so the egg cannot travel from the ovary to the uterus. And then just the presence of the disease itself can have a negative impact on fertility. So the tissue of the endometriosis releases these inflammatory cytokines that sometimes prevent ovulation from occurring and prevent sperm motility, and can also just make it more difficult to conceive just by the disease being present in general.
So in reading up on the disease, I stumbled across some experts who say that endo alters the immune system and has also been linked to cardiovascular disease. How so?
So again, the production of inflammatory markers created by the disease creates a chronic inflammatory state within the body. So it's not considered an autoimmune disease, but it does affect the immune system, and women who have endometriosis do have a higher risk for cardiovascular disease like heart attack and stroke, probably related to that chronic inflammatory state that occurs within the body.
This is so interesting because I've always kind of downplayed it when somebody has said they have endometriosis. But when you keep calling it a disease and that it's an actual thing, and we can kind of dive deeper into explaining it, it really comes into focus how it's altering someone's life who has it.
It affects so many aspects of patients' lives who have the disease.
Glad you're here. We're glad you're here.
Well, thank you.
All right, let's get to some community questions this morning. And Cindy wants to know if endometriosis is hereditary. So Cindy's sister had it, but Cindy does not.
So we don't know. We do think there is a genetic component to endometriosis, and we don't know exactly what gene or hereditary factors drive that. But if, say, for example, your mom or your sister has endometriosis, you have like a 7 to 10-fold increased risk of having the disease yourself. So we know there's some genetic predisposition to the disease, but it's not fully understood how that works.
Jeremy says, congratulations, Abby. And I just mentioned I was one of these people. Well, why does it seem so common that it gets sometimes dismissed? Why is that so?
Well, I think part of the problem is just lack of education, even amongst OBGYN specialists. In our training, we get very little education regarding endometriosis. Sometimes, like most medical students, probably receive 1 to 2 lectures about endometriosis, despite being how common it is. And even in OBGYN training, we get very little education. And then beyond that, the surgeries for endometriosis are very challenging due to the way that it affects the organs. And so most endometriosis specialists need additional surgical training even after their residency to become proficient in treating this disease surgically.
You're very passionate about this. You know, what drives that?
I just think it's people like Abby that I show up to work every day and hear these stories day after day. And, you know, I realize how frustrated they are, and again, they are often dismissed. And so I just like being able to help people out and, you know, help them to have those answers that they're seeking and hope to improve their quality of life and achieve their family goals like, you know, Abby is able to here. And so just really appreciative of Abby able to come on and share her story today, because these are the happy endings that we're hoping to try and to achieve for all of our patients.
Stu wants to know, he says, you said endometriosis has no cure. What is the status of Abby's endometriosis? Is it in remission, as we might say?
Well, I guess, Yeah, it's hard to say because there's no natural course of the disease. There's no predictable thing that will happen. Abby could go on for many years without any problems, or within a few years we could go back and maybe there are new implants or disease. So it's hard to predict, and sometimes the decision to go back for surgery is not often an easy one. But that's why it's important in an initial surgery to try and do a good job of removing or resecting all visible disease, which is often not the case for many patients who have surgery for endometriosis.
And Becky wants to know if for women diagnosed with endometriosis, should they be monitored more for ovarian and other cancers?
We don't recommend any increased screening. Definitely if there were abnormal findings like large cysts on the ovaries, and especially if they chose to not have surgery related to that, certainly we would follow that with imaging and have maybe a higher index of suspicion for something weird or unusual happening. But in general, we don't recommend any increased screening for patients with endometriosis in terms of cancer screening.
Trudy wants to know if women diagnosed with it can look to IVF for help in getting pregnant. Are they good candidates?
Yeah, they are often good candidates, and for many patients, especially with more advanced disease where they have damage to the fallopian tubes, IVF may be an only option for some patients. And so that's one of the things we try and do here too, is work with our fertility group at KU, who I think does a really good job of that as well, in collaboration with surgery and family goals. But sometimes IVF, it's definitely a reasonable option for many patients with endometriosis, and sometimes the only option based on their level of disease.
Dr. Finley, what do you want the big takeaway from this conversation to be? Now that we're talking more about it,
Sure.
There's more to learn, but what do you really want women to know and be aware of with their bodies?
I just think that women know their bodies and we should listen to them, and that's what I think we do really well here at KU, is we listen to people and take their complaints seriously. And not every person that has those symptoms will necessarily have endometriosis, but if you come here, something that we will do is take your complaints seriously and help you to, get the answers you're looking for and provide you excellent care for, endometriosis.
Get that second opinion if you need to, right?
For sure, absolutely.
Abby, thanks so much for sharing your personal story with us, and we're so happy that your pregnancy is going well. What do you want other women to know, and what do you want people to take away from your personal story?
Yeah, I think for me, it was definitely just about advocating for myself, and I was really thankful that Dr. Finley was so willing to listen. I felt like he was the first medical person I talked to that was just like, okay, let's look into this. Yes, let's schedule the surgery. And so I think just it is important to advocate for yourself, and like Dr. Finley said, your body, you're not crazy. And so just taking symptoms, even if it doesn't lead to being diagnosed with endometriosis, taking them seriously and pressing in and not letting yourself be minimalized, and just taking yourself seriously.
Well, be well. Thank you so much.
You.
Thanks to both of our guests today. Thanks to you for spending your morning with us. We invite you to invite your friends and family to watch. Have a great weekend. We'll see you back here on Monday.
Coming up Monday on the Morning Medical Update. More movement, better memory. I'm Alexis Del Cid. On the next Morning Medical Update, see the workout class backed by science, empowering people with dementia and Alzheimer's. Why caretakers call it a lifeline. Monday at 8 a.m.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.